Hi, it's Dr. Centeno, and thanks so much for joining me this Sunday morning. Got an interesting topic to talk about today. Basically, we're going to get into the different kinds of orthobiologics that are commonly used to treat craniocervical instability. And it's kind of an alphabet soup. So I think a lot of patients get confused from time to time. So that's why I think it's good to go through all of this to try to make sure everyone understands what these terms mean, what's being described, what those things are good for, not so good for, etc. As usual, I'll go through sort of 10 minutes or so, sometimes 15, but usually 10 of a lecture, information. Then you can ask questions about that topic or really any topic at all. So again, just if you're just joining us, we're going to focus today on orthobiologic types, what's out there, try to decode the alphabet soup, and then obviously go to an extensive Q&A. If you're interested in asking questions, just put those in the comments wherever you are, whether you're on Facebook or YouTube. Just put your question in the comment. Obviously, the earlier you put your question in, the easier it is for me to get to. And then also realize I'll take some questions off of the Reddit sub. So I'll probably start there to answer some of those questions since those were submitted before. And then I'll get into some of the questions that are being submitted now. But again, I would make sure that you get your questions in early. And that's because many times there's so many questions, I don't have an opportunity to get to them all within this hour time frame. But we'll spend an hour today. So let's get into this topic, right? An overview of the types of orthobiologics used in CCI, or craniocervical instability. So what are orthobiologics? They're substances that can promote repair or improve maintenance of ligaments, joints, tendons, muscles, and nerves. We've got autologous, which is from that person, and allogeneic, which is from another person. Now, there are also chemical types as well, so we'll get into that a little bit. So the two main concepts are chemicals that are used to promote repair, and tissue. And that's going to be what we just talked about, autologous and allogeneic. If we go on the chemical side, this is really where orthobiologics kind of started way back when. It's an interesting history. If you go back in time, prolotherapy was quite popular in regular old routine medicine through the 1930s and 40s. There was even a prescription drug called Sanusol that was used for ligament prolotherapy. So interesting, though, at some point, because they were doing blind injections back then, some physician stuck this stuff into the spinal canal and into the dura, and someone got paralyzed. The problem with chemical type orthobiologics is they cause a brief inflammatory response by causing some local chemical debridement, and that can injure nerves. So you can't use these around nerves. So that's why it kind of fell out of favor. Then come the 1980s, and it kind of comes back into favor. So the two chemical types of orthobiologics are prolotherapy and D5W, at least the two most common. So in prolotherapy, what is it? It's a hypertonic solution, which means a solution which is more concentrated. And by being more concentrated, it causes a chemical debridement, which is literally local isolated cell death. And then that kicks off another bite at the healing apple or an inflammatory response. We understand how this works because of that chemical debridement. Debridement just means, getting rid of or killing off. And the research backing, pretty good. There's some randomized controlled trials, lots of case series. Having used prolotherapy for 30 years, I can attest that it really works well. for less severe ligament and tendon injuries. And as far as good and bad Prolo, it's not really so much the difference between the product, although some different things can be injected, but it's really the differences between how it's injected. And I've talked about that quite a bit through the years. The downside, as I've said before, is since prolotherapy causes a local chemical injury, you can't use it around nerves. So if you were to inadvertently inject this stuff into a nerve, that's a bad day for everybody because it's going to cause nerve injury. So that's the downside with Prolo. And one of the reasons why I always talk about Prolo needs to be done under imaging guidance, because you don't want to inadvertently inject this around a spinal nerve. You don't want to inadvertently inject it into the spinal cord or around the spinal cord, all that stuff. D5W, this is a 5% dextrose solution in saline or anesthetic. The good news is it's now not toxic to nerves. There's some theories about how it may help nerves. It's really unknown how that works. There's lots of theories, though. The research backing is a bit less than even prolotherapy, and it's really good for nerve hydrodissection. Sometimes it'll be used in epidurals as well. Again, just like prolotherapy, there's not much difference in what's injected, but there is a big difference in how it's injected. So again, this is really where technique comes in, imaging guidance, etc. And the downside is that if you compare it to platelet-rich plasma and platelet lysate for use around nerves, we have much more data that PRP, for example, will help nerves than we do for D5W. So let's get into the tissue-based orthobiologics. So the three main autologous types, blood, bone marrow, and adipose. I'm not going to go into adipose because I don't see adipose being used all that often in craniocervical instability. The reason likely is that adipose tissues, subcutaneous, aren't involved in ligament healing, whereas bone marrow is. And so consequently, you just don't have that native ability of those cells to repair ligaments like you do with bone marrow and blood, which are both involved in day-to-day ligament healing. So if we get into blood, we've got platelet-rich plasma. That's going to be come in two flavors, leukocyte-poor, which is amber, leukocyte-rich, which is red. You've got platelet lysate, platelet-poor plasma, and then some gimmicks like platelet-rich fibrin and platelet-rich and growth factors. So PRP, what is it? It's blood that's taken usually from an arm. It's put into a centrifuge, and you concentrate the platelets in the plasma, i.e. platelet-rich plasma. The likely mechanism of action is the growth factors and exosomes that are within the platelets, and those degranulate or come out over a period of time and help coordinate a repair response. Oops, sorry about that. It's good for arthritis in joints like facets, less severe ligament tendon injuries. And as far as good or bad PRP, concentration does matter quite a bit if you're treating an older patient. If you're treating a 25-year-old, it probably doesn't matter. If you're treating a 45-year-old, it probably matters a lot, i.e. more concentrated PRP is much better in that case. The downside, that since this is taken in a routine blood draw, it would be considered to have a higher risk of sterility for breaches. So what I mean by that is that if you are just taking blood from an arm and using an alcohol swab, there's a higher likelihood of having some sort of sterility breach and introducing bacterial contamination into the PRP. That's as compared to bone marrow, which is taken using a surgical prep. Platelet lysate, what is it? Basically, blood is taken and used to create PRP. Then those platelets are broken open or lysed to get the growth factors and exosomes out. Mechanism of action is pretty similar to PRP, although the growth factors are right there. They don't have to degranulate out of the platelets. There's a few randomized controlled trials, mostly case series. It's good for epidural use and peripheral nerve use. Again, if you're older than 30, concentration is going to matter here. And same real issues as PRP. There's a higher risk for sterility breaches, a little bit mitigated by the fact that the lysis component here may kill off some bacteria. So that probably mitigates some of that risk. But for example, if we're using it in epidural use, we'll use a 0.22 micron filter to both filter out the platelet bodies and prevent any kind of bacteria getting into the epidural space, where it would be a much bigger deal than even if it got into a joint. Platelet-poor plasma, what is it? It's basically a byproduct of PRP preparation. That means it's the fraction that you're sort of left over with after you create PRP that doesn't have a lot of platelets. So it's really just plasma. Now, likely mechanism of action is cytokines and growth factors in the plasma that can help with inflammation and healing. Research backing, much less data is available on PPP. What's it good for? We think it's really good for muscle injuries. And as far as good versus bad, PPP, not much of a difference. And again, same downside as PRP with regard to sterility breach possibilities. Bone marrow. You've got bone marrow concentrate. You've got culture expanded stem cells, which I won't get into since they're not legal in the United States. And then a gimmick alert here would be mu cells. So let's get into BMC. So for bone marrow concentrate, this is called BMC. It's also called BMAC or BMAC, bone marrow aspirate concentrate. Basically, this is when you take a bone marrow aspirate from the pelvis, and that looks like sort of thick blood. You then take out the cellular fraction using centrifugation, kind of like PRP, and you end up with these nucleated cells in plasma, a small percentage of which is going to be stem cells and other cells. The likely mechanism of action here is going to be through mesenchymal stem cells, and again, other cells, i.e. macrophages that are within the mix. The research backing is less than PRP, but there are multiple randomized controlled trials. We've published a bunch of those. Felipe Hernigal has published some as well. And there are many published case series. What's it good for? Arthritis in joints, that is more severe in the case of CCI, like facet joints, and more severe ligament and tendon injuries. Good versus bad BMC, that stem cell content matters a lot in how well it works. So in order to improve that, that's both dependent on the quality of the bone marrow aspirate. Most of them were not high quality, regrettably, and the concentration technique used to isolate those cells. And the downside is really that it's more expensive to take and process than PRP, and it has more limited quantity than blood. Allogeneic cells, these are cells that come from umbilical cord, amniotic, placental products, but they contain no living or functional stem cells. They do contain growth factors. One of the reasons we don't use them in CCI at all is that there are multiple FDA warning letters out there regarding sterility and processing issues with these tissues. As a result, we never want to expose someone to a product where we couldn't have a high likelihood that that product is actually sterile. So let's get to questions here. I will jump out of this here, and we will get to questions here. I'm going to start first just with some of the questions that were submitted on the Reddit thread, since those are the oldest here. Let's see here. Don't know what's going on there. Let's try this here. Sorry, guys, having a little bit of technical trouble. It shouldn't be happening. So anyway, I'll just ask the questions. I've seen some comments on fasting pre-post PICL. Does pre-post fasting help with stem cell yield or recovery? Any other prep recovery supplements or dietary suggestions? We don't really know how fasting impacts orthobiologics procedures. We believe due to some basic science data that it may help. But I think it's probably better just to do good, clean, healthy living. And if you go on the Regenerative website and you look under resources, you can find a book by Dr. Pitts on basically dietary recommendations. Next question. During EPICL, is the bone marrow concentrate mostly used up in CCJ? Is it usually also used up in injection sites like the lower neck? I would say in the vast majority of patients, we have bone marrow concentrate left over. And because of that, we try to use that in other spots. Now, that's after injecting the internal ligaments and everything we need to do posteriorly. We usually have stuff left. For example, that could be used in the lower neck, that could be used in a shoulder, that could be used in treating the SI joints, etc. Next question. Why does bone marrow concentrate hurt more when injected into the facet joints? Because it's more pro-inflammatory. And in the average patient who didn't have CCI, it would probably be reasonably tolerated. But a high percentage of the CCI population has some sort of central sensitization or difficulty managing pain. That's one of the reasons why we don't start there. Let's see here. For large advanced disc bulges, would you go straight to BMC or MSC? Or would you still try leukocyte or PRP or PL first? A lot of that's going to depend on what's going on with that disc bulge. So for example, the first thing we do is to use a DDD approach that's not injecting the disc, that's trying to stabilize and tighten the ligaments around the area, treat the beat up facet joints, treat the nerves that are irritated, etc. If that didn't work and there was still good disc height, then leukocyte-rich PRP intradiscal would be the next way to go. And if for some reason that didn't work, bone marrow concentrate or culture expanded hypoxic condition mesenchymal stem cells would be the next thing to try. Let's see here. I think those are it, i.e. from the ones that I've probably already answered online here. So let's get to the formal questions here. Casein, if 90% of amniotic stem cells are dead upon the stems, let me read that again. If 90% of amniotic stem cells are dead upon same-day injection, why aren't the same percentage of PRP cells also dead upon injection? Yeah, it's a lot more than 99. It's pretty much all of them are dead on arrival. Casein, the reason why those cells are dead on arrival is the process in which you get any of those birth tissue cells. So if you walk through that happens, what usually happens is that these are public hospitals that are understaffed. Why are they public hospitals? Because most private hospitals, parents are paying to save that stuff. So they're public hospitals that are understaffed. That tissue gets put aside. It's dirty at that point, meaning there's no way to sterilize it in the hospital. So you put it aside, it goes in the fridge, it stays there until someone picks it up. Then someone drives it across town. Sometimes someone drives it to the airport, puts it on a plane, and then flies it someplace. It then gets to a tissue processing center. It sits for a while until someone can get to it. Then they process and do what they're going to do. Then they bottle it and then cryopreserve it. And then it gets transported, saved for months and months and months, sometimes years. And then it gets transported to where it's going to be used. Then it is shock thawed in the doctor's hand. Now, that's completely different than platelet-rich plasma, where you're taking blood, you're taking out the platelets, you're then going ahead and putting those platelets in hours after they've been taken out of the body. So as you can see, there's a stark difference there between how the two are processed. And as a result, that changes how the two are going to survive all of that processing. Or even BMC cells, what percentage are dead, same day collection and injection? Yeah, very few. So we do a live dead stain on all of our cells. And in general, the average viability is usually in the low to high 90s, somewhere in there. Casey, it sounds like adipose-derived cells aren't part of your treatment. Other clinics use them a lot. Is there something they don't? Yeah, so Casey, I think it really depends on how you want to deploy those cells. So for example, adipose-derived stem cells might be good in a knee joint. The problem is I'm blanking on the guy's name from Emory. Let me just say there's a recent Emory study that shows that bone marrow cells were superior to adipose cells in knee joints. And then you get into using them in CCI, we'd really be using them for a ligament function there. And for ligament repair, like I said before, that's not natively what those cells do. So if you get close to the native function of the cell, then you're more likely to have that cell help that tissue. So in the case of a ligament, bone marrow is often involved in ligament healing. If a ligament gets torn off the bone and there's a bony injury, bone marrow seeps into that whole thing. Bone marrow cells can also transit into that ligament because ligaments are attached to bone. So you have a higher likelihood of ligament being helped by bone marrow-derived stem cells than you would adipose. And there's more data on that. Maisie, if neck pain becomes dramatically worse after an upright flexion extension MRI, which ligaments have been affected? I don't know. I mean, that's a calculus equation with 30 variables, right? At the end of the day, that would be hard to say. You might postulate that some of the ligaments involved in checking flexion extension could be involved. So, for instance, in checking flexion, you would have the supraspinous ligament, the nuchal ligament, the VDL, the PAOM. In checking extension, you would have the SAAOL, the AAOM. You would have the ALL, etc. Having said that, more likely than not, an upright MRI with flexion extension didn't injure ligaments, but probably caused irritation of structures that were causing symptoms. So most likely thing that would happen would be irritation of those structures, not damage to ligaments. And I think the problem you're having there, and I see this all the time online, is you're making the assumption that the symptoms are caused by damaged ligaments. Hence, if I have more symptoms, I must have damaged more ligaments, and that's regrettably not accurate. Symptoms are caused by injured structures like joints, like nerves, etc. Would injury of an already stretched ligament cause the normal pain and swelling response? Would injury of an already stretched ligament cause normal pain and swelling response? I don't know that I can answer that one as phrased because I'm not quite sure what's being asked there. Maybe try to re-ask that question a different way. Maisie, can you tell me a little bit about the tectorial membrane? Sure. The tectorial membrane goes just behind the dens, and it would be an extension of the posterior longitudinal ligament coming up on the front of the spinal canal. And it would be involved in helping prevent that dens from going back into the spinal canal. Greg, my dentist told me that having your premolars taken out, which were taken out as a kid, can lead or contribute to forward head posture. Have you heard of this before? You know, Greg, I haven't heard of that before, and that's something I think more appropriate for a dental specialist, kind of outside of my area of expertise. Let me stop there for a second. Guys, if you could give me a like, comment, share, subscribe. At the end of the day, that's how people find this content. If you enjoy having a doctor that spends his Sunday mornings with you to answer your questions, then for other CCI patients to find this and to help pay it forward in that CCI community, you got to do that so that they can find this content and then join us here to get their questions asked. Hello, Mark. E. Smith, I've heard of people having 5 PICLs, but never 6. There's a hard limit of 5. There isn't a hard limit of 5, although I have to say that once we get much past 4 or 5, I start cautioning patients that they might well be fusion candidates. Now, if we've gone that far, usually the patient has had some good amount of help. So that's why they're continuing. So each and every time we have that discussion, is this the time we want to peel off and go to a fusion if you're not done yet? Or are we seeing enough iterative improvement here to really warrant continuing? Yes, thank you so much, Greg. I appreciate you bringing that up because, again, that is how this content gets found, and that's how other patients can participate, get their questions answered, etc. So thank you so much. Vero, good morning, Dr. Centeno. Does the odontoid pannus go away if instability is fixed? Not usually. The problem, Vero, is that by the time we get pannus, that's usually an area that is scarred down, and it's no longer just swelling. It starts out as sort of a swollen bursa, but over time it gets beat up and scarred down in most patients. So it becomes sort of a fixed item that usually doesn't go away. Now, if we get it acutely, we've seen a few of those where you can see the fluid in the pannus. We have seen those go away. Casein, what's the composition of buffy coat? That includes mesenchymal stem cells, hematopoietic stem cells, macrophages, various types of white blood cells, platelets as well. So that's most of it. There'll be a few other cells in there, but that's going to be most of what would be considered important. D07, how does CCI impact CSF flow? Cerebrospinal fluid flow can get disrupted by craniocervical instability at the area behind the dens there and in front of the medulla and spinal cord because the dens becomes too close to that medulla spinal cord area. It can also get reduced by pre-existing Chiari malformation, which is where the cerebellar tonsils hang too low, and that can reduce CSF flow in the back part of the spinal canal. Now, that's not one that's usually put there by CCI, but if it's there and asymptomatic, it can cause more symptoms because it allows less room in that foramen magnum area. Blessed, if the jugular vein is being compressed from misalignment due to loose ligaments, can this be fixed by EPICL? Yeah, Blessed. So jugular vein compression statically is found on incidental imaging, meaning someone that went in for something else, not CCI, and they saw jugular vein compression is pretty common. There's lots of people walking around the street right now who have compressed jugular veins, and they function just fine. They function just fine because anytime any vein is compressed in the body develops collaterals around that vein. Literally, new veins go and root around, or other veins get bigger to compensate. It becomes an issue with intermittent compression in CCI because it's positional, right? It's not static, it's intermittent. And intermittent compression, we have less of that collateralization going on. And so the goal with treating CCI would be to get additional stability so that that ongoing intermittent compression doesn't continue. Finnegan, my DMX shows 10 millimeters over lateral flexion overhang on the right, 8 millimeters on the left. Do you think it's safe to try for cervical chiropractic like Nuca or Atlas orthogonal? I can't answer that question. I don't do that work, and I don't know your clinical history. So Can't answer that one. Blessed, can an excess glide on C01 cause symptoms? If so, what are the main symptoms you see with this? I think what you're talking about is CCI type 1C, where there's sliding of the skull on the atlas. And we tend to see upper cervical symptoms with that. So symptoms related to the C0C1 facet joint, which is pain at the back of the head. You can also get irritation of some of the cervical nerves that I describe on my YouTube channel through the transverse process of C1, usually irritating those various nerves. So that could be vagus nerve, that could be hypoglossal nerve, etc. Does having MRI done by Dr. Rosa help you guys as doctors inject better? Yeah, it's wonderful to see those MRIs from Dr. Rosa. They're well done. He can frequently help identify some structures to inject. But what I always tell patients is it really depends on which camp you find yourself, right? If you're in the, you have a lot of resources camp, and you're not going to be changing your treatment plan by getting an expensive MRI done, then definitely see Dr. Rosa. That will be very helpful for us. If, on the other hand, you're resource constrained, like many patients, and you don't know if you're going to have enough to do 2 to 4 PICL procedures, then we can probably get it done without that imaging. So it really depends on where you find yourself from a resource standpoint. What do I do? Qualification. I am trained in physical medicine rehab. I'm one of the fathers of modern interventional orthobiologics. So one of the first humans on earth to do these procedures, one of the first humans on earth to publish on the use of these procedures. So I do interventional orthobiologics. What that means is all the stuff we talked about before via precise injection. And more importantly, this last couple of years, as I move towards retirement, since I've restricted my time in clinic, I'm focusing more and more on just treating craniocervical instability while my partners treat everything. Sir, can, I believe, orthobiologics be used in gouty arthritis? That's not one we have treated a lot with orthobiologics, so I'll have to say I don't know the answer to that one. Rheumatologist resident, great. Greg, when do you decide to add higher dissection of vagus and stellate ganglion to EPICL? Is it strictly symptom-based or when performing the procedure? Yeah, it's going to be symptom-based and history-based. So, for example, if someone has a history and symptoms consistent with vagus nerve, then we'll do it. As far as stellate ganglion goes, we don't do that one quite as often, simply because we found there really isn't a need if you're going to be hard dissecting that space, because the stellate ganglion is probably getting doused in platelet lysate as well. Before EPICL, are you put to sleep for bone marrow aspiration? You are put to sleep with an IV for bone marrow aspiration. Now, I would say 80% of the patients are sleeping, maybe 20% of the patients, because they take a lot of medications, or more in a deep twilight kind of thing. But the goal is to get you asleep for that bone marrow aspiration. It's also important to note that you don't have to be asleep. We used to do it without IV anesthesia. And so it's important to understand and realize that patients can do it without IV anesthesia and just local numbing as well. Can pressure irritate CCI? Would it be better to fly or drive to Centeno-Schultz Clinic if pressure not an issue? Could hyperbaric help for lymphatic drainage and other things caused by CCI symptoms? Not sure what you mean by pressure. If you mean like pressure fronts, cold fronts, things like that come through In my experience, that does impact people with joint pain, and CCI can include facet joint pain. As far as flying or drive to Centeno-Schultz Clinic, a lot of that really depends on how well you do with flying or driving and how far away you are. I would say 90 to 95% of our patients fly. And then as far as hyperbaric help, we don't do hyperbaric, so I can't really comment on its efficacy for lymphatic drainage. E. Smith, sorry. Growth hormone is released in deep sleep. How does poor or disrupted sleep affect healing from orthobiologics? Would an insomniac heal, or someone with sleep apnea even heal at all? Yeah, E. Smith, I would say that you want to work on your sleep to the extent that you can. For example, if you have known sleep apnea, then use a CPAP or find other ways to mitigate it. Sometimes it's mitigated via an oral appliance, which you may or may not be able to tolerate if you have CCI. Sometimes it's mitigated by simple things, right? Trying to make sure that you don't sleep on your back, for example. So you should try to get good sleep. Now, the problem sometimes is it's a chicken or the eggs scenario, right? We have CCI patients that just don't sleep well because it's uncomfortable to sleep, and we can't get them to being more comfortable until we treat them. Now, do we have people with disrupted sleep who do fine with the procedure? We do. We have a lot of them. So while I think it's good for maximizing outcome, it's probably not required for an outcome. Blessed, how can you get higher quality of bone marrow concentrates, certain food supplements, etc.? Well, you can certainly eat well. We've got a stem cell support formula, but the biggest difference in bone marrow concentrates is going to be how the doctor takes the bone marrow aspirate. I've said this before in various lives, but 90% of the time, the doctor is doing the bone marrow aspirate that's convenient and quick for the doctor. So that means they put the trocar in, they just fill up their syringes, and they're done. Regrettably, that type of bone marrow aspirate really reduces the number of stem cells that are available. In order to maximize the number of stem cells, it takes more time and energy than that. So in order to maximize the number of stem cells, you have to go to either multiple bone sites or multiple depths and take no more than 5 mLs from each bone site or depth. So that means you're taking from both sides, usually 3 bone sites each side and multiple depths per bone site. And if you do it that way, it takes more like 30 or 40 minutes. Versus 5 minutes, but it maximizes the number of stem cells. James, does lymphatic clearance improve post-PICL? I don't think we have any way of measuring lymphatic clearance at this point, so hard for me to say that. In EPICL, do you also take blood from the arm for PRP, strictly just use BMA? In EPICL, we usually do not take blood from the arm. We just go through the BMA. The reason for doing that is, as I said in the little mini lecture I just gave, it reduces the likelihood of a sterility breach because you're in a surgical setting, right? You're doing a full surgical prep and full surgical sterility in taking a bone marrow aspirate, which is quite different than just sort of using an alcohol wipe here on the arm and taking blood. It's one of the reasons why I would never use PRP for an EPICL, because it ups the risk for that sterility breach and an infection. And an infection in that area, and thank God, knock on wood, we haven't had anything like that happen in more than 2,500 procedures, meaning a deep infection. It could be a real mess. So I don't want to take any increased risk by using PRP over BMA or BMC. James, is intracranial compliance normalized post-PICL independent of CXA correction? Yeah, James, I can't tell you that. I can tell you that people with pressure headaches have their pressure headaches go down. I can tell you that patients who have symptoms of increased intracranial pressure, have those symptoms go away. But as far as measuring intracranial compliance, that's not something that's easy to measure even before a procedure, certainly not after. Deniscope. Do you take suggestions from Dr. Rosa where to inject, especially if we have spinal fluid flow issues? We do, and that's one of the reasons I said if resources are not the driving factor, then seeing Dr. Rosa is fantastic. It helps us a lot. Having said that, if resources are the driving factor and you're struggling just to be able to afford a procedure like an EPICL, then we can usually get where we need to go without that data. So if you want to optimize outcomes and you've got a lot of resources, absolutely see Dr. Rosa. Vera, if we don't want opioids after PICL, what other pain med options are there? Yeah, Vera, well, the first one would just be using just extra strength Tylenol. Another one could be using drugs like Lyrica. A third would be using an opioid similar drug, but not quite an opioid. That would be something like tramadol. So those are usually the things that we look at. And we certainly have patients that just take Tylenol. They're not interested in doing anything else. Robert, if you suspect one C0C1 joint is unstable, do you still inject both? Yeah, Robert, as far as the joint is concerned, we're injecting which one is symptomatic. So that's both based on a palpation exam and a pain referral analysis. So for example, let's take it down a level, right? If it's C1-2, we know the C1-2 joint has pain like this, right across the back of the skull here. So if I palpate C1-2 joint, and that's where the patient has pain, I know I'm going to add that to the list. Now, C0C1 would be pain more like this. Again, if I'm palpating 0-1 and it's tender, and they've got the appropriate referral pattern, then we're adding in 0-1. James, does a reduction of C1, C2 overhang correlate with measurable changes in pontomedullary angle and brainstem strain metrics? Yeah, James, I think you're confusing two different types of CCI there. You're confusing a type 2B where you've got side-to-side motion of 1-2 or excessive rotational movement of 1-2 with a hyperflexion of 0-1 with a low clavoaxial angle, which is CCI type 1A. So you're confusing two different concepts there, meaning we have type 2B patients that don't have type 1A, most of them don't. So there wouldn't be any overlap in those two Venn diagrams. And obviously you wouldn't expect reducing C1, C2 overhang to do anything to a problem with a low clavoaxial angle and brainstem strain because they're not related to each other. So it's a little bit like apples and oranges. James, does a regenerated tissue restore native collagen crimp patterns, or does it form linear fibrosis that sacrifices viscoelasticity for tensile strength? James, I don't think anyone knows the answer to that question right now because it would require you to biopsy tissue after the procedure. That would be pretty much impossible to do in this clinical application, a PICL procedure. Probably pretty hard to do for something like an ACL. Maybe something you could do in, for example, a Achilles tendon. In fact, there is an Achilles tendon study with PRP that showed significant improvement in collagen after the PRP injections. But in the other two clinical applications, no study exists. I can tell you, though, from examining a lot of ACLs in our 4 ACL studies, including randomized controlled trial, that the end feel of the ACL returns to normal in patients that respond. So, for example, that's using either a drawer or a Lockman's test on the tibia, where you can feel that prior to the procedure, you're dealing with an incompetent ligament that has a poor end feel, and then that end feel gets normalized after the procedure, very similar to the other one. So that's the best I can tell you there. Robert, have you done PICL on some with functional CCI where they can still do general living? Oh yeah, Robert, I would say on average, about 1 in 5 of our patients are higher functioning patients who still do quite a bit. So they would score, for instance, on that neck disability index in the mild to moderate level, but realize that most of them live in what I call a functional box. If they go outside of that functional box, then they get a lot of symptoms. But yes, that's pretty common. Ian, I had a consultation with you a couple of years ago and sent you my upfront MRI with flexion, maybe upright MRI, with flexion, extension, rotation, and my CT scan. You advised they were inconclusive for CCI, but possible vertical instability. I needed DMX or similar for more conclusive answers and before being offered PICL. I've now had open mouth, ear to shoulder, not flexion, but maybe lateral bending x-ray. Would this suffice? And can you look at these? Nobody offered DMX in the UK. Yeah, Ian, that's basically how we would get that done in the UK, for example. So you should have my email address. Feel free to send those to me, and I'll be happy to take a quick look at them and tell you what I see. MRSDM. C1 is rotated and pressing on cranial nerve 11 and causing issues with the trap and SCM not being able to activate. My shoulder drops and pulls my neck and jaw. Is shaving the transverse process an option? Certainly wouldn't be the first option, right? It's a big surgery. Lots of important stuff there that can get injured. So it wouldn't be the first thing you would consider. Might be one possible option, but prior to that, you would consider conservative care, which would be, for example, upper cervical chiropractic, physical therapy. If that didn't work, depending on the type of CCI you have, looks like you're maybe describing a CCI type 2B, you might consider something like an EPICL procedure. And then if that didn't work at all, you might consider either something like you're describing or actually maybe better defining what's causing that issue with cranial nerve 11. So that might mean some additional imaging, that might mean some additional physical exam, because at the end of the day, that wouldn't be the most common area of compression for that cranial nerve. But if it were, then you might consider, and you knew that that's where it was coming from, you might consider the big surgery you're discussing. But you're kind of putting the ladder of invasiveness upside down, right? And which really only maximizes risk to patients. So in medicine, we try the least invasive thing that's most likely to work. If that doesn't work, we go to the next invasive thing. If that doesn't work, we go to the next invasive thing. You wouldn't want to start with the most invasive thing from the start, because then you're increasing your risk. Surgery, the only choice for degeneration, cervical myelopathy with chronic symptoms. I need to know more. There's a lot of different parts and pieces that we can unpack in that question. If what you mean is that there's no visible changes in the spinal cord on MRI, but there might be a small indent in the cord, and then that's what you're defining as myelopathy, then we treat that all the time without surgery. I have that, so I can tell you I'm a living testimony to that one. If what you mean, however, is that there's true myelopathy, where there's damage to the cord occurring that we can see on MRI, for example, and or physical exam, then surgery may be a better option. But those are there's fine lines between those two. It's not as simple as, aha, look at that on my MRI. Ian, I get very bad head pressure when bending over or head downwards. I have no head pressure in other positions. Is more likely to be cerebral fluid issue or venous issue, and CCI the likely cause of this symptom. Yeah, I mean, there's lots of things that cause head pressure. That can include everything from irritation of the occipital nerves back here to swelling in the ADI area bursa or upper cervical bursa, to intermittent occlusion of the internal jugular vein, to possible disruptions in cerebral spinal fluid pressure. So I don't know which of those is most likely in your situation, not having seen you for many, many years. But the best I can say is that you would want to get to a good diagnosis of what's causing the head pressure in order to determine what the next treatment looks like. E. Smith, do pull-ups directly strain the cervical ligaments? They could, but I would say for the most part, probably not. But again, a lot would depend on your clinical situation. Blessed, is it common for CCI patients to have cerebellar tonsils hang low? Yes, it's very common for our CCI patients to have CTE. I would say that's present in 50 to 60%, let's say 60% of our CCI patients. A lot of that is probably because it's a risk factor for more symptoms. So there are probably people out there who have CCI and don't know it because they've got no issue with low-hanging cerebellar tonsils. But if you have low-hanging cerebellar tonsils, the theory goes that you've got less room there and are more likely to get symptoms. (5:26 p.m. Lisbon). Good to see you, Steve. For those with high pressure tension around the CCJ, even vascular insufficiency, does healing phase of PICL increase such? Pressure tension around the CCJ. Robert, not quite sure what you're describing there, meaning during the flare phase of a PICL procedure, you may get increase in symptoms, including those. With regard to the healing phase, so let's just sort of break that down, right? You've got initial inflammatory phase where people usually have a good amount of symptoms. Then you get into the donut hole where new tissue is getting laid down. Then you get into the remodeling phase. So most of those increased symptoms would occur initially either in the inflammatory phase, or they might be better in that phase due to tissue tightening, or in the donut hole. I have severe tremors which subside with a neck roll while supine. They also cease when I put my hands behind my head. Is this something you consider seeing in your clinic? Yeah, it'd be an atypical presentation for craniocervical instability. So we'd want to try to make sure that we could tie those tremors to your neck and that there'd be no other reason for the tremors outside of craniocervical instability. So other things that we might ask a patient like that to try would be putting on a cervical collar, for example, locking out the neck, seeing if that gets rid of the tremors, those sorts of things. James, what MRI biomarkers definitely distinguish acute facet trauma from background degeneration to refute workers' comp pre-existing condition denials? Kind of two different things there, James, one being scientific, the other being administrative. I really don't want to comment on the administrative workers' comp craziness. But as far as what kind of things would you look for in acute facet injury, that's going to be problematic on MRI, primarily because the joints are small enough where we can't get a really good look in those joints. So for example, tuomi has published on the fact that you can detect, or you can't detect on MRI, what a facet joint looks like, but you then, in patients that die of other causes, go and do histology of the joint, and you can see breaks in the bones, you can see breaks in the cartilage that really aren't visible on MRI. I would say if you really wanted to try to take a look at something like this or make a go of it, you'd probably need a 3 Tesla MRI with thin slices through the joint to see if you can detect any acute bone marrow swelling around the joint surfaces, swelling within the joint. But again, some of that's also going to be present in chronic facet joint issues as well. Greg, with both CCI and DDD, SI lumbar issues, do you prefer to start top down or bottom up? Usually both at the same time. So what that means is, for example, if it's a type of CCI that requires PICL, then we will treat the CCI during a PICL procedure, but we'll also treat the SI joints at the same time. Vero, does the pannus cause problems further down the road? That's possible, but I think unlikely. Most pannuses don't cause problems unless there's also something else there. So again, a little bit like those low-hanging cervical tonsils, it's usually pannus plus CCI equals symptoms, and not just pannus alone. JS, is CXA only measured accurately with a motion study maybe, or flexion extension MRI? The best way to get CXA is with an upright MRI. That's going to be the most accurate, although you can get it from a CT scan. You can get it from a supine MRI as well. The reason why we like upright MRI with flexion extension with CXA is that it allows the person to stress that area, and we can see if the CXA gets lower and goes below those metrics that we have. We also have normal or at least asymptomatic values for CXA and upright MRI. Ian, how do you manage someone who has obstructive sleep apnea during a PICL procedure? Yeah, we manage it pretty carefully. And what I mean by managing it pretty carefully is that we first have the new Gen 5.5 mouthpiece, which does a great job of managing it all by itself. But usually in those patients, we are, I would say, dancing with the airway. What do I mean by that? What I mean by that is that we are frequently stopping during the procedure to make sure we're managing the airway to optimize breathing. Then we'll do some procedure. Then we may need to come back to optimize the airway, do some procedure, etc. Blessed, does low cerebellar tonsils always mean Chiari? I'm not sure what you mean by Chiari, meaning that low cerebellar tonsils that just touch the foramen magnum, or a line that goes across the foramen magnum, would be considered CTE or Chiari 0. One of the things I think that many Chiari patients get wrong is that Chiari is symptomatic all by itself. It's usually not, especially not in a Chiari 0 or 1. So it's really something else plus Chiari. That could be craniocervical instability plus Chiari. Since there's a lot of people walking around with low-hanging cerebellar tonsils that are totally normal and have no problems and never will, probably not worth worrying about low-hanging cerebellar tonsils. Vera, how many weeks after PICL can we do dry needling on the upper back and suboccipitals? What about prolotherapy on the knee? As far as dry needling goes, I would give it a good 3 or 4 weeks. As far as prolo on the knee, there really wouldn't be a restriction there. Greetings from Germany, upright MRI, which says during movement of the head left and right, the distance between the spinal cord and ligament transversum shrinks to under 1 millimeter as this CCI. No, that's not a known measurement where we can clearly state that that's symptomatic CCI versus just a normal variant. So I know in Germany, they love doing the upright MRI or lie down MRI with head turn. Regrettably, that's not a super sensitive way to detect craniocervical instability in my experience. So we're often in this situation where we get MRIs from Germany and we're scratching our heads saying this doesn't show craniocervical instability based on the metrics we have established. James, is the fibrosis created by PICL destroy the mechanoreceptors within the alar ligaments, effectively trading mechanical stability for permanent proprioceptive blindness, loss of position sense? No, James, we wouldn't have any data that even suggests that fibrosis is created, and we certainly wouldn't have any data that you would lose mechanoreception. In fact, it would be quite the opposite, right? For example, in our ACL patients, where we inject the ACL ligament under X-ray guidance in a similar way to the PICL procedure, those patients do lose proprioceptors and mechanoreception when they get the ACL ripped out and treated surgically. They don't lose that at all when they get treated by injection, nor would it make sense, meaning that the goal of bone marrow concentrate is to heal the ligament, which would mean also preserving those proprioceptors or mechanoreceptors. So that one doesn't make common sense, and it isn't consistent with what we know based on the peer-reviewed literature at this time. JS, who do you send your patients to for surgery for degenerative disc? That's an easier one because there's usually lots of people in the local community who can easily treat cervical degenerative discs with fusions, etc. So we don't really send them to specialized surgeons like we do for upper cervical fusion. Casey and where along the vagus nerve is the needle inserted for vagus nerve hydrodissection? Usually KCN that's done around the C2 area. Dr. Mellison, I have been doing physical therapy, which seems to make my CCI worse. Should I stop that prior to my PICL procedure? Yeah, I would say that if physical therapy is making you worse, it's either not appropriate for your current condition or not the right kind of physical therapy. So best at this point to just focus on stopping that, let things calm down, and then you can talk to your doctor about when to restart. Robert, back to the sleep for bone marrow, or maybe being asleep for bone marrow aspirate. What made you change from not doing it to doing it? Is it fear or pain that governs that? Yeah, Robert, I would say that when we weren't putting patients to sleep with a bone marrow aspirate and just using local numbing, about 70% of the patients would do really well with it. They had some maybe pulling sensation. Some had very little sensation. Some had pulling sensation, and we would manage that during the procedure. About 30% of the patients found it really uncomfortable. And then in the CCI population, that number is even higher based on the kind of pain they have. Realize that we were doing that frequently for knees and shoulders and hips, so not someone with chronic spinal stuff. Okay, guys, it's coming to the end of the hour, so I'm going to take some questions from people who haven't gotten anything in so far, rather than just same stuff from same people. Nathan, is type 1C more difficult to make a full recovery from if there's no support in the back of the atlas to cradle the skull joint properly? You're relying on ligaments only, essentially. So I think what you're talking about, Nathan, would be the lack of a ball and socket joint at C0, C1, and realize that all of those type 1C patients had no problems until they did, right? Usually what happens is that lots of people probably injure their upper neck ligaments. Maybe they get a little loose. But if they have that ball and socket type joint at 0-1, they never develop symptoms. If they have a more sliding joint there, then they do develop symptoms. So the goal is getting the ligaments back to as normal as possible there. Let's see who else hasn't asked a question yet. TT, if someone sees Dr. Rosa to optimize outcomes, what imaging do I ask him for? He will know. So you'll be getting, in all likelihood, an upright MRI with CSF flow monitoring, flexion extension. Again, trying to get to people that haven't had a chance to get a question answered here. Tanya, hello. If you try prolotherapy, how many sessions would you say you should do at most to be able to say if something is going on? Assuming upright MRI, the ligament are affected, and then prolotherapy is done weekly. Number one, upright MRI wouldn't be usually a valid way to diagnose a problem with the alar ligament. And then two, prolotherapy wouldn't be a way to address that alar ligament problem. So, just realize that that type of alar injury, if present, isn't going to respond to posterior injections back here because you're not getting anywhere near those alar ligaments. Stephanie, are you aware of any advancements in AI that may help CCI patients or that can help you take the EPICL to the next level? Not really, but that's certainly going to happen, right? We're starting to use more AI in the analysis of the data. For example, I think as that gets better and better and better, we're going to see AI help to take unstructured medical data and turn it into insights from really the first time. So I think that will improve over the next number of years quite a bit. Right now, we are using it in data analysis because it can be very helpful there, although you do have to hold its feet to the fire, and you do sometimes have to double and triple check to make sure it's answering correctly. Let's see, again, trying to get to folks who do not have questions in. Kevin, good afternoon, Dr. C. Will a vagus nerve hydrodissection help also with dizziness? Usually not, Kevin. Usually the dizziness has nothing to do with the vagus nerve. It's more the upper cervical facet joints. So usually you have to get those treated. Julie, what's the most common cause of tight SCMs and tightness across the throat? I would say usually C1, C2 instability. Rishi, can you inject lower cervical facets via ultrasound only? You can, you just can't do it well. And what I mean by that is that there are many, many times when we're injecting lower cervical facet joints under C-arm with contrast that we don't have good flow in the joint. And you've got to change your needle position in order to make sure that the stuff you're injecting is going into the joint. When it comes to lower cervical facets, you really can't see that well on ultrasound. So I always say you can inject some of these spinal structures with ultrasound. You just can't inject them well, meaning that you don't have the higher level of confidence like that you do with contrast and C-arm fluoroscopy that the stuff you're injecting is actually getting where you think it's getting. Derek, sorry for going off topic, and people treated with basically a powerful biologic for psoriasis have the PICL procedure. You'd have to be off that powerful biologic for two main reasons. One is it's going to dramatically increase the infection rate, something we wouldn't want with a PICL procedure. And the second would be that it's also going to block inflammation, which is how this procedure would work. Evelyn is a thickened nuchal ligament caused by a botched neck rotatory brake adjustment, a ligament that can be treated with PICL, determine grade of thickening or damage first. That's one that's very easy to access with just posterior procedures, so you wouldn't need a PICL for that at all. You can do that one very easily under ultrasound guidance, just posteriorly. So it wouldn't require something like a PICL. Aaron, something music. I understand 7 out of 10 patients, the improvement after PICL. Is there an estimate of patients who return to baseline versus some improvement? Not sure what you mean by there. Maybe you're asking in the 3 out of 10 patients that don't respond, are some of those people that maybe get some initial benefit and return to baseline? Yes. That would be part of that group. Some of that group would be no response. Okay, let's see here. Hate to be morbid, not really morbid, but are there promising physicians that will be able to pick up EPICL in the wake of your retirement? I'll give a Mark Twain quote here. Reports of my death have been greatly exaggerated. Mark Twain once said that. Listen, I don't anticipate completely retiring anytime in the next 2 or 3 years, probably after that. But yes, we have already trained Dr. Schultz and Dr. Pitts in my practice how to do this. Dr. Merkel is also trained up on how to do this. We'll train other doctors in our practice. We're working with the Florida group to train them. So yes, now it's not a see one, do one, see one, do one, teach one situation where we've had doctors show up and watch the PICL and then attempt to go, after watching 1 or 2, go and do it themselves, which is dangerous and irresponsible in my opinion. This isn't the kind of procedure you can do that with. So it takes a long time to get these doctors up to snuff and to make sure that they're doing everything correctly. But yes, reports of my death have been greatly exaggerated. I think that's it. JS, thank you for your generous time to inform and Q&A, one of the best podcasts available out there. Well, thank you so much, JS. Yeah, guys, like I said, it's important that other patients join us here because they can learn by your questions. They have questions of their own. So do me a favor, if you haven't already, give me a like, share, subscribe where you are. And I'm going to be ending this up because I think we're at about 1 hour and 13 minutes now. And I want to thank you for all of your questions. As I always say, we all learn by getting questions answered. Sometimes we learn by getting other people's questions answered. So I really appreciate you taking the time to be here and asking all these great questions. I will be here next weekend, I believe on Sunday. And I may tackle how to deal with PICL recovery, because again, like I always said, we tend to see waves come and go in social media. And one of the waves that's cresting right now, I think, is patients being very confused about how to recover from a PICL procedure, and some of them pushing that panic button. Now, a couple of weeks ago, I did one on pushing that panic button and how that can result in negative things. So I may go further into that and talk about some of those different trajectories in PICL recovery and what to expect and how to deal with that. For example, patients will contact me and say, well, I had a flare-up. Why? And one of the first things I ask is, did you stop medications for the procedure? Oh yeah, I stopped 2 medications that were controlling my symptoms. Did you go back on them? No, that kind of stuff. So anyway, that's what we'll probably do next week. But thank you so much for taking the time on a Sunday morning, and have a great week. And I will see you back next weekend. Thank you.